Assalamu alaikum. Good afternoon. Thank you, Dr. Hassan, for this introduction. It's my pleasure to share, as usual, the annual very successful scientific VTE meeting arranged by Dr.sheef and all the organizing committee in King Fahd Medical City. I will share my presentation. Okay, I will overview over the VTE prevention among medical patients. As we can see in the latest ASH guidelines, they highlight the patient groups in a medical patient as 4 groups: acutely ill medical patient, critically ill patient, chronically ill medical patient, and also they introduced the long travel the distance as one of the medical group patient where they need VTE prophylaxis. So as all our colleagues today, they highlight on the venous thromboembolism and the need for appropriate prevention among hospitalized patients. The VTE is a leading cause of morbidity and mortality in hospitalized patients. While numerous randomized controlled trials, they have shown that the appropriate use of thromboprophylaxis in hospitalized patients at risk for VTE is safe, effective, and cost-effective. It still remains under used or inappropriately used. HAD, which is the hospital-acquired VTE, is our target today. That's why we need annual awareness for all healthcare providers to prevent the hospital-acquired VTE. The hospital-acquired thromboembolic diseases is occurring during hospitalization or within the 3 months after hospitalization. They has been shown to underlie more than 50% of all cases of the population burden of VTE. And VTE in medical inpatient has multiple causes for that, and the rationale that half of VTE event occur due to hospital admission for surgery, 24%, or medical illnesses, 22%. And if we look to the risk factors for VTE in hospital include cancer, old age, prior VTE, central lines, immobility, all of this you will find it with the patient admitted to the medical floor. 40% of hospitalized patients, they have 3 or more risk factors for VTE, and the increase in thrombosis risk in medical inpatient persists 45 to 60 days after discharge. So the process of thromboprophylaxis should include assess the risk of VTE, as it was mentioned in the morning sessions, assess the risk of prophylaxis and bleeding in the same time. Prescribe the appropriate thromboprophylaxis is very important. And it's the role of the healthcare provider to weigh the risk and benefit of thromboprophylaxis, to weigh the risk of VTE against the risk of bleeding, the risk of death or morbidity and expected cost, malpractice choose in the arm of the VTE and in the arm of bleeding, wound infection, surgical failure, adverse effect, unnecessarily caused malpractice also should be balanced, both of them. So how to stratify the risk of developing VTE? It's a group approach. It was published in the test in 2012, and they stratified the patient into very low risk, moderate, and high risk. And this according to the incidence of the presence of cuff DVT, proximal DVT, BE, and fatal BE. And if you notice here, moderate, they have the highest cuff incidence DVT, 20 to 40%, proximal DVT 4 to 8, and the clinical BE 2 to 4, while the fatal BE is 0.4 to 1. The risk assessment models, as was mentioned before, is a lot of risk assessment models, and like Cabrini, Kochers, Roger, Padua, Improve, Geneva, Apex, a lot of them. And if you look to most of them, they have an overlap in the risk factors, and which is the famous that's being used in the medical patient is the Padua risk assessment, which include the prior VTE, major surgery, age, cancer, thrombophilia, immobilization, obesity, and hormone treatment, and other clinical medical illnesses patients need admission to the medical floor. So according to those risk assessment we use in the medical patient, we will calculate the points, and according to the points, patient will be certified as either a low risk, moderate risk, or a very high risk that he need, from moderate to high, need appropriate thromboprophylaxis. The ASH guidelines, they were published in 2020, and they look to the patient who is at risk for VTE in the hospital. And the risk assessment model can identify inpatient at high risk, and they look for those used Padua and improved VTE scores, and they compare the risk factors for both. The Padua risk score, they have previous VTE, thrombophilia, active cancer, patient age more than 70, reduced mobility, recent trauma or surgery, heart respiratory failure, acute MI or stroke, hormonal treatment, obesity more than 30, infection, rheumatology. In the improved VTE RAM, they look to the previous VTE, which is almost the same, thrombophilia almost the same, active cancer is almost the same, but the age group, they went for a younger age group, more than 60. Immobilization, which is almost the same in Padua, which reduced mobility. Lower limb paralysis was added here. ICU and CCU stay. So it's an overlap between the risk factors with increased modification on the improved VTE RAM risk assessment. And they come with the guidelines, the ASH group, the American Society for Hematology Clinical Practice guidelines for updated for prevention in medical patient. They look for how patients and clinicians should use their recommendation. And they make the recommendation into two groups, either strong recommendation, conditional recommendation. Strong recommendation means for patient, most individual would want the intervention, and for the clinician, that most individual should receive the intervention. Conditional recommendation is the majority would want the intervention, but many would not. And for the clinician, different choices will be appropriate for different patients depending on their value and preference, use shared decision making. For that, they make in each recommendation, they will write either it's strong or either it's conditional recommendation. The first question, the ASH group, they put, should any parenteral anticoagulant like unfractionated heparin, low molecular weight heparin, or fondaparinux versus no parenteral anticoagulant be used in acutely ill medical patients for VTE prophylaxis? And if pharmacological prophylaxis is used, should low molecular weight heparin versus unfractionated heparin be used? If pharmacological prophylaxis is used, should the fonda versus low molecular weight heparin be used? And they give a recommendation for the acutely ill medical patient. When they wrote the recommendation, it looked to the outcome. Well, the outcome is looking to the mortality, PE, symptomatic proximal DVT, and major bleeding. And they make a quality of evidence grade as a low, moderate, or strong. Strong is the green color, and the moderate is the orange color, with the low risk is the red color according to the outcome. For the BE in acutely ill medical patient, the relative effect was 0.59, 10 per 1,000, and is 4 fewer BE per 1,000 patients. For that, the panel, they suggest using unfractionated heparin, low molecular weight heparin, or fondaparinux rather than no parenteral anticoagulant. And they make it as conditional recommendation, low certainty. That depends on the clinician. He can override if he finds that the patient needs to be on more stronger thromboprophylaxis. The second question the panel raised for the acutely ill patient, should mechanical combined with pharmacological VTE prophylaxis versus pharmacological VTE prophylaxis alone be used in acutely or critically ill medical patient? And also they make this as conditional recommendation. They suggest using pharmacological VTE prophylaxis over mechanical prophylaxis, and the pharmacological prophylaxis compared with the mechanical prophylaxis graduated compression stocking, and they look to the outcome, the mortality, the PE, the symptomatic DVT, major bleeding, were all of a low quality of evidence in such a group for what they make it as a conditional that the healthcare provider or the physician can override this recommendation. Other new updated also guidelines, the ASH group, they raise it whether to use the wax in acutely ill medical patient for VTE prevention. And for that, they also they compare the mortality, the PE, the symptomatic proximal DVT, the major bleeding. And major bleeding was found to be a strong quality of evidence. Relative effect 1.7, and the risk with a prophylactic with a low molecular weight heparin was 2 per 1,000, and the risk of difference with any DUAX was 2 more bleeds per 1,000. For that, they did not recommend to use the DUAX compared with the prophylactic low molecular weight heparin in those patients, and they make it as a strong recommendation. The questions also was raised by the ASH group, should extended duration pharmacological VTE prophylaxis after discharge, that's mean 30 to 40 days, versus in-hospital only pharmacological VTE prophylaxis be used in acutely ill hospitalized medical patient. This is a little bit had a dilemma a long time ago, whether to discharge a patient for extra 30 or 40 days on prophylaxis or not. And they recommend inpatient over inpatient plus extend duration, outpatient VTE prophylaxis, and they make it as a strong recommendation. And they look to the mortality, the BE, symptomatic proximal DVT, major bleeding, and they were of the major bleeding and symptomatic proximal DVT were of moderate quality of evidence, and they recommend only inpatient over inpatient plus extended duration. And in a medical group patient also recently, over the past 2 years, we passed by the COVID patient admitted to the medical floor, and they were in the need of appropriate VTE prevention. So the ASH group, they recently published that VTE has emerged as an important complication for a patient hospitalized with COVID, and the early reports documented the high rates of VTE, and in particular BE, for patients hospitalized with COVID-19 related acute illness and critical illness, despite pharmacological thromboprophylaxis. And they look for the role of anticoagulation in those group of patients with COVID-19, and they come up with the 2021 guidelines on the use of anticoagulation for thromboprophylaxis. And that was based on the study done that the ASH formed a multidisciplinary guideline panel and applied the strict management strategies to minimize potential bias from conflict of interest. And they include 3 patient representatives. The McMaster University Grade Center, they supported the guideline development process, and they include performing systemic evidence review up to 19 August year 2020. And then they prioritize the clinical question and outcome according to their importance for clinician and patient. And they use the grading of recommendation, development evaluation grade approach, include grade evidence to decision framework to assess the evidence and make recommendation, which were subject to public comment. And they describe the COVID patient, their target population into 2 groups, critically ill and acutely ill. The critically ill, they define them as patients with COVID-19 who develop respiratory or cardiovascular failure, normally requiring advanced clinical support in the ICU or CCU, but they could include admission to another department in the ICU. CCU was over capacity. And ICU, CCU capacity and admission criteria should vary according to the specific setting. For acutely ill patients, they are patients with COVID-19 who require hospital admission without advanced clinical support, not to the ICU, not to the CCU. It could be in the regular floor, but they include treatment in other settings if the hospital was over capacity. And the hospital capacity and admission criteria could vary according to the specific setting of those patients. And they come up with the recommendations that using prophylactic intensity over intermediate intensity or therapeutic intensity anticoagulation for patients with coronavirus disease to COVID-19 related critical illness who do not have suspected or confirmed venous thromboembolism, and they make it as conditional recommendation based on a very low certainty in the evidence about the effect. And the second recommendation for the ASH guideline, they suggest using prophylactic intensity over intermediate intensity or therapeutic intensity anticoagulation for a patient with COVID-19 related acute illness who do not have suspected or confirmed VTE, and also make it as conditional based on a very low certainty and the evidence about the effect. So in conclusion, it's very important when it's medical patient or other non-medical patient, we need to know what it covers, why it matters, the DVT prophylaxis, who it affects, what it covers, who should receive an intervention, and what that intervention should be. Intervention considered include anticoagulant medication or mechanical compression. And we need to, why it matters, because the medical inpatient, long-term care resident, person, and minor injuries and long-distance traveler are all at increased risk of VTE together with COVID patient. And the guidelines recommended the best approach for preventing VTE in this population while minimizing unnecessarily or over treatment. Who it do affect? Medical inpatient, including those in intensive care unit, long-term care resident, person with minor injuries, long-distance travelers, other medical illnesses, and healthcare provider working in the hospitals. So what are the highlights for prevention in medical patients? For patients who are hospitalized, risk assessment is very important. At the same time, we have to assess the bleeding risk and choose the appropriate effective prophylaxis for them. In medical inpatient at a high bleeding risk who require prophylaxis, the mechanical prophylaxis is preferred over the blood thinning medication. In medical inpatient at a high VTE risk, but acceptable bleeding risk, the anticoagulation or thromboprophylaxis is preferred over mechanical prophylaxis. Keep in mind that the ASH guidelines is against use DUAX in a critically ill patient. In a medical inpatient, when a medication is used to prevent VTE, that's the pharmacological thromboprophylaxis, the low molecular weight heparin during hospital stay is preferred over direct oral anticoagulant, and the use of combined modalities in medical inpatient, that's mean mechanical and pharmacological thromboprophylaxis, it's not necessarily unless the patient is a very high for developing VTE, it can be combined as per all the guidelines. This my last slide is to summarize. When we prescribe appropriate prophylaxis, we have to assess the risk of VTE, whether it's low or high. If it's low, there is no prophylaxis need. If it's high, we have to choose the appropriate VTE prophylaxis, and we have to weigh the risk against the benefit. Assess the risk of bleeding is very important. If the patient is low risk for bleeding, then we go for pharmacological prophylaxis. If patient is high risk for bleeding, we go for mechanical prophylaxis. And we have to follow the guidelines, which drug, initial timing of the drug, and the duration of prophylaxis is very important. Thank you very much.